Satish, are you there? Am I audible?
Sir, yes, sir. You are audible, sir.
Okay, sorry. Thanks.
ராம்குமார் மியூட் ஆயிருக்கு.
Good evening.
நீங்கப்பா எங்க இதுல இருக்கீங்களா இல்ல எங்க இருக்கீங்க?
இல்ல sir, I just reached home, sir, for this meeting to attend.
வாரா மதுரையில.
After 8 days, sir, came to home, sir. So Salimani sir has joined.
ராம்குமார் இவங்க நம்ம பிரசன்டேஷன் கொஞ்சம் லாஸ்டா வச்சுக்கலாமா? எனக்கு கொஞ்சம் அப்படி இது பண்ணிட்டு இருக்கேன்.
சரிங்க sir. Then actually I will start from this thing, sir.
The cases, then
Madhu sir has joined, sir. Then whomsoever they're joining first, we will start, sir. Don't be the problem. Salimani sir, hi, sir. Salimani sir has joined, sir.
சரி, ஓகே. கடைசியா வச்சுக்கலாம் நம்ம. கடைசியா.
Yes, sir. In between நீங்க ஓகேனாலும் we'll go ahead, sir. Don't be the problem.
ஷூர்ப்பா. செல்லிமணி சார்ட்ட சொல்லிடுங்களா ஒரு வார்த்தை. இருக்காரா? ஜாயின் பண்ணிட்டாரான்னு தெரியல.
Yes, sir. He already joined. Salimani sir, hi, sir.
இல்லன்னு நினைக்கிறேன்.
Yeah. Hello, Vijay. I'm just joining.
Sir, good evening, sir.
Yeah. Slowly. Yeah.
Sir, இந்த
Yeah, Vijay. Good evening.
நல்லா இருக்கீங்களா சார்?
Good. Nice seeing you. Yes.
சார் ஒண்ணும் இல்லைங்க சார். இந்த என்னோட பிரசன்டேஷன் லாஸ்டா வச்சுக்கலாங்க சார். Just
Okay. Sure.
slides லாஸ்டா.
Sure. We'll do that.
சார் நான் விஜயகுமார் சார் சொன்னேன் எனக்கு கோவப்பட்டார் சார்.
என்னடா
இது விஜயகுமார் சார் ஒன்று சொன்னேன், அவர் எனக்கு கோவப்பட்டாரு.
ஏன் என்னது?
ஜூலி ஆஃப் தமிழ்நாடு காட் ஆஃப் இமேஜிங் சொன்னேன் சார் அவரை.
ஆமா அது அவர் அதுல டெடிகேட்டடா ஒர்க் பண்ணிட்டு இருக்காரு.
எஸ் சார், எஸ் சார், எஸ் சார். வி ஆல் லேர்ன் ஃப்ரம் சார் ஒன்லி சார். இன்னும் சாரோட பென்ட்ரைவ் வச்சிருக்கோம் சார்.
Yeah.
பத்து சார், குட் ஈவினிங் சார்.
ஜாயின் பண்ணிட்டேன். மது.
Good evening, boss. Good evening, George.
Hello, good evening, Prabhu.
Good evening, sir. How are you, sir?
Good.
We'll wait for another 2 minutes, sir. Then we will go live, sir. Sir, Madhu sir, actually, your presentation is ready now, sir. We can go with the first presentation. It won't be the problem, right, sir?
Yeah, my presentation is ready. I can go with that.
Yeah, okay, sir. Then we'll wait, sir. So if delaying means, then we'll start with Madhu sir presentation. And Manogar sir
Okay.
also joining in some time. Yeah.
I think Saravanan sir also joined, sir.
Good evening.
Yes, sir.
Yes,
Hi, sir. Hi, sir. Hi, sir.
நீங்க இதுக்கு ஸ்கிரீனை காணோம்.
Good evening, Salamani sir. Good evening, sir.
Yeah, good evening, Saravanan.
They have posted my presentation as the first one, sir.
Yeah,
It's
yes, Saravanan. You will be
ready, sir.
presenting. Yeah.
When you
So
say
I can see Madhu, Saravanan, and only 2 of you, and anybody else? Dr. Subhash, are you available there?
Sir, you can go to the gallery mode, sir. Then you can see everyone. Subhasa is
Yeah.
already.
Yes, sir.
Yeah. Subhash sir, good evening.
evening.
Nice seeing you.
Good evening, Dr. Selhamani.
Good evening, sir. Good evening.
I'll be waiting.
Fine.
Sir, Lijo sir also joined, sir.
Yeah, good evening, Dr. Lijo. Good evening. So I think Ram, we are set to go. I think whenever you say, we will start off.
Yes, sir. So technical team ready for recording?
Ram, will you guys start the slides?
Yeah, again, good evening, everybody. It is a pleasure to have this 8th round of 9th. Somebody's, I think they're having 2 speakers. And this is the 9th round of this current guidelines OCT in ACS and chronic coronary syndrome. All this webinars, we have had a very good interaction and a lot of people participated. And last week also we had 2 of these webinars. And today we have extremely experienced operators and speakers. And Dr. Vijay Kumar is here, who has been pioneering imaging for so many years now. And of course, we have Subhash Chandra, a very senior intervention cardiologist from Delhi. And of course, all our Dr. Licho is there. And then Dr. Dharmaraj is yet to join. And Dr. Sarvan is already there. And we have Nitish Kumar and Anand from Dindikal. And we have Madhu already joined us. So I think with this, we are set to go now. We'll kick off with this, and I think Vijay Kumar will be presenting in between or as a last presentation. Until such time, I think we'll start off with Dr. Saravanan. It's over to you, Saravanan, sir.
Thank you, sir. Thank you, sir. At the outset, I would like to thank Abboud for this academic meeting. I will just share my slides. Are my slides visible?
Yes, sir.
Yeah.
I'll go ahead, sir. So this is a utility. I'm just going to present on the utility of orbital atherectomy in acute coronary syndromes. This is a case of a 60-year-old gentleman who presented with chest pain at rest. He was a diabetic, hypertensive, and a smoker. ECG showed ST depression in the lateral. It's 1 AVL V5 V6. Troponin was more than 1000. A diagnosis of non-ST elevation ACS was made, and coronary angiogram showed a tight lesion in the LAD and the obtuse marginal artery, and RCA had intermediate disease. The LAD was heavily calcified. So this is the angiogram. There was significant disease in the OM as well as a heavily calcified lesion in the LAD. So here Viper wire was used to directly cross the. So we decided that it was a good vessel, 3.5 size vessel. So we decided to use orbital atherectomy upfront. So I wired directly with a Viper wire. So I directly wired with a Viper wire crossing the lesion. Then orbital atherectomy at 80,000 RPM was done for around 5 cycles, and 120 RPM was done for around 3 cycles. So initial we did at 80k RPM for 5 cycles and 120 RPM for 3 cycles. Then I pre-dilated with a 310 NC balloon. So post orbital atherectomy, there was a good luminal gain. So post orbital OA, I did a NC with a 310 NC balloon around the 16 atmospheres. So this is the OCT image. Sorry. Sorry, I think the post orbital OCT is not playing. So post orbital, the pre-dilatation was done with a 310 NC balloon. So there was good luminal gain. So then I stented it with a 3/33 drug-eluting stent. Post-dilatation was done with a 315 NC balloon distally and a 3.510 balloon proximally. The post OCT runs, the OCT run is not playing. Sorry for that.
Yeah, I'm having, sir. Shall I share or?
Yeah, please, Satish, can you please share the OCT images, because in my thing iPad is not sharing. So the final angiogram showed good expansion, and the final OCT run also showed good expansion. Satish, are you there? Can you just share the images? So I'll just close my presentation.
Yes, sir. Is it visible, sir?
I'll just close mine. I'll just stop sharing.
Yeah, we can see the OCT. Play that.
Yeah, please play that. Yeah. This was the post pre-run post the sorry. This was the post OA run, OCT run post orbital atherectomy. You can see the nodular calcium. There is thick concentric calcium also. So there were cuts in between the calcium with the orbital atherectomy. We did 80K cycles, 80,000 RPM. We did 5 cycles, and 120,000 RPM. We did 3 cycles. So there was cut in the calcium. Satish, can you show the post OCT run, post stenting run? The post OCT run, there was good stent expansion and good apposition. So we post dilated with the 315 distally and 3.510 proximally. So and the final angiogram showed no distal dissection or perforation. OCT runs also showed good expansion and good apposition with no edge dissection.
Okay,
Thank you.
Satish, can you run the first OCT, that is immediately after orbital?
Pre-days, sir, you were asking?
Yeah,
Post OA run. Yeah,
post OA,
Yes.
pre-stenting. Yeah. Okay. So yes, sir, Ronan. Very nice case here. So how did you opt that you need some atherectomy for this case here? What was your criteria? How do you select whether a patient requires an atherectomy or just a balloon? How do you decide? You are
For this
muted.
patient, sir, this gentleman, he was present at the ACS and had angina, sir. So this LED lesion was around to me around 85 to 90. So I decided to go upfront with orbital. Previous this kind of cases, we initially tried balloon, and balloon did not cross. So 2.2 balloon New York we did not cross. So we decided to go with the upfront orbital. I had an orbital backup upfront. So
Okay,
but I did not try any one balloon. Did not try any one balloon. Sir.
No,
Just
but
two
here
balloons.
you tried 2 balloon and balloon did not cross, huh?
No, sir, not for this case, sir. I'm saying
Not
for
this,
previous
previous
experience. This kind of
Oh,
cases,
okay.
balloon did not cross. This case, I went with the upfront orbital because it was a heavily calcified lesion. So I knew definitely I have to be upfront. So this was around my third orbital case. So I was still comfortable with the Viper wire. So I just directly wired with Viper and then started OA runs and then stent leads.
Okay, anyway, post stenting OCT shows very good stent expansion. So you used 3 and 3.5 balloon. You did not use any other balloons, no? Did you use any?
No, sir, only
scoring,
3.5, sir. No, sir, no, sir.
Any scoring or any cutting balloon?
No, sir, no. I did an initial orbital run. Once the orbital run was over, I pre-dilated with the 310 NC.
Okay. Any comments from other people here, other people in the panel? Dr.
Your-
Subhas or somebody has to comment on this?
Yeah. Your runs were confined to 80,000? Because this
No, sir,
vessel is
5
pretty
cycles.
sizable. What was it?
It was 5 cycles with 80,000, sir. Three cycles with 120,000.
Mhm. Perfect. Because the size of the vessel demands that it should also be done at 120. Because usually we end up using 80, but an excellent case. And I'm sure the calcium HVCT is substantially thick. So one could weigh between using an IVL for it or just doing it with the orbital orbiter. So I think you've done excellent. Yeah, thank you.
Thank you.
So you saw some nodules also, no?
Yes, sir.
And did you feel that the orbital has touched that nodule?
Sir, still there was a protrusion was there into the lumen, but with the 120 we did 3 cycles, sir. I didn't want to go further. I was still afraid whether I would cause any perf or anything. So after 5 cycles with 80K and 3 cycles with 120K, we saw that, and I felt okay. I'll just put an NC and see if it expands well. We'll leave it at that.
Okay. Okay, nice, Saravanan. So probably like until probably the next speaker gets ready, you can tell us something about the orbital. You have done 3 cases, no? What
Yes, sir.
precautions do you take? Have you come across any problem with that? How comfortable are you using it? Have you
Sir,
used it in some other cases, like where, as you said, balloon did not cross? Was
yes,
there
sir.
any?
I used it in a RCA, sir. Heavily calcified RCA. Gentleman presented with an inferior volume. He was post CAPG and heavily calcified RCA, post CAPG, RCA graft got occluded. So native RCA attempted initially, balloon could not cross. So even one balloon did not cross, sir. So we wired with initially with a cyan blue wire, and I exchanged the micro catheter and put the orbital viper wire, and then I did an orbital run, sir. I then orbital run at 80K and 120K, and post stenting there was good results, sir.
No, no.
So
Did the orbital go easily, or did you
it
have?
went, it crossed in glide assist, sir. It crossed initially in glide assist, and then initially started with retrogradely, and then did anti-glide also.
Okay, good.
So it was mid-distal junction, sir. It crossed freely with glide assist mode, sir. I did not have any trouble.
Okay. So anybody else want to comment something? Madhu, you want to say something, or you want to go ahead with your presentation? No, generally. Yeah.
That was an excellent case, Saravanan. So well done.
Thank you, sir.
So generally, while deciding a use of atherectomy in calcified lesion, each institute has a different protocol. Like probably you go by angiogram and decide. And it was easy, probably it was not so critical. Why you did not try imaging before orbital? Any idea?
Sir, actually we have house OCT, sir, but thing is with these calcified lesions, even this New York OCT catheters, we have had problems. Sir. 2 times I have burnt my fingers. The New York even OCT catheter did not cross, and it got damaged also. So
no, in this case, did you try?
No, sir. No, sir. I did
No,
not try,
okay,
sir. But
okay.
previous this kind of cases we have tried twice. New York OCT catheter got damaged, sir. So I decided whatever it is, we'll do some upfront, some like you said, cutting or some or atherectomy, and then go ahead with OCT, sir.
Okay, post orbital, did you see any effect of this orbital on the calcium? Could you make out?
Yes, sir. Definitely, I could appreciate few cuts in the calcium, sir. So and then NC balloon also, then 3:10 expansion was very good. So
okay, very nice, Sarunan. Very good demonstration, and probably demonstrates. Probably you can use orbital in a probably bigger vessel. Generally, we tend to use 1.2 when the vessel size is more than 3.5. And definitely it's a bigger size, as Dr. Subhash Chandra also pointed out. You have done it, and then probably it's a good result without any complications there.
Sir, there is one question in chat box, sir. So
I saw that. That is what I asked. Like probably it was a deep calcium. Did that help? Deep calcium in that OCT. How that helps? See, actually, this OCT was done post-orbital. So probably the orbital itself has made some luminal gain there. And I could see that it has touched some areas of nodule and some areas of sanding was seen. But although it was not a very classical sanding that we could see in routine post-orbital OCT, and it will be seen very clearly if it is a still more critical tight superficial calcium. But of course, that is why we were discussing the indication of orbital or any atherectomy in this. It is always, you can do it in, the protocols differ from institution to institution. And again, Hariharan is saying after OAD, NC balloon is used. And I asked that, and he did not use any cutting or scoring balloon. Only NC was used. That is what he has said.
So just to add, one can modify his decision at the stage of pre-dilatation. So one has to see the expansion of ANSI balloon in two orthogonal views. And if you feel the balloon is nicely expanding, there are no constrained sites, it is the call that you perhaps will not require IVL in such cases. Because deep calcium, as was shown in one of the runs post orbital, clearly shows that yes, one could be compelled to pick up IVL also in this case, because there's a nodule there, there's a thick layer of calcium there. But luckily here it gave way to the NC balloon dilatation.
Correct,
So
sir.
that is another test which can help decide. That's it.
Yeah. Okay, I think we'll go with who's the next presenter? Dr.
Madhu sir
Yeah.
is in the next presentations.
Madhu, I think you can start your presentation.
Okay, sir.
Madhu, you are not audible. I think you can start talking also.
Sir, you are muted, sir.
So is it audible now, sir?
So now we can hear you.
Okay, sir. I'll share once again.
Yeah.
The slides are visible, sir. Is it visible?
Yeah, we can see. We can see. Make it full screen.
Okay, sir. So, good evening, everybody. So, this is about the case is about how to exactly identify the nodular calcium, which is not very much seen with the routine angiogram. So, this is about the 72-year-old gentleman who came with features of STEMI. So, he was taken off for coronary angiogram. So the angio shows there is some calcified lesions in the proximal LAD, and you can see the tight the proximal LAD showing around 90 to 95% stenosis. So this angiogram, as you can see here, the lesion is the very tight one, 95%. Otherwise, all of the LAD, there is some minimal blocking is there. The one area which I had a doubt is this area. As you can see here, it looks like some filling defect. I thought it was a thrombus, but I'm not very sure whether it's a thrombus or something else, this area. And in this view, I could not see much of that particular filling defect. So the filling defect in acute coronary syndrome, most of them we take it as an thrombus, but I had my doubts because there was some proximal calcium in this particular area. So there is a doubt here. So this right coronary artery, it shows some borderline lesions in the proximal and mid RCA. So the pre-dilatation was done with 2.0 into 12 NC to facilitate the OCT catheter insertion. So the pre-PCI OCT was done in the LAD. So this is the OCT run. So it shows a tight fibrous stenosis here. And in this particular area, there was a calcified nodule on the both sides. I will show the still pictures the next screen. So the OCT pictures in various places. So in the proximal, it was predominantly fibrofatty with fibrofatty lesion. And here, the fibrous plaque is there. And this particular area, after the diagonal, it was a fibrofatty with the macrophages. So this particular area, where there was a filling defect, it showed nodular calcium. So here from 10 o'clock to 1 o'clock position and from 3 o'clock to 7 o'clock position. So two nodules were seen here. So similarly, fibrocalcific 180-degree arc of calcium is seen as well. So this particular area, this is the tightest one. So the calcium, so the maximum arcs of 3 quadrants, the distribution around 8 mm, the thickness is 1.1 mm. So this is the distal LAD reference of 2.75, mid 3.35. So, and proximal reference is 3.3. So after that, we decided to go with the orbital atherectomy. So this is the exchange of the microcatheter from exchange of the microcatheter wire from run through to Viper wire. So orbital atherectomy debulking was done with 80,000 RPMs. 5 runs was done, but 5 runs were done. So only the calcific segments were treated with the orbital atherectomy. So this is the post-orbital atherectomy, OCT. So which showed the nodular calcium being treated well, and there was a cracks in the nodular calcium as well. So this is the orbital atherectomy. So differential sanding. So as you can see here, so this is the proper luminal gain in various areas which I already described. So the nodules, the nodular calcium, there was a luminal gain with the breakage of the calcium as well as the arc of the calcium was broken. So I used cutting balloon 3.0 into 10 to further dilate the lesion to prepare the bed for the stent. So this is the drug-eluting stent deployment. Distal was 2.5 into 18 mm mid to distal segment, and proximal was 3.0 into 33 mm mid to distal overlapping stent. So post optimization was done with the 3.5 into 1 MC bulb. So the post PCA OCT run was done. We showed the good expansion of the stent and opposition of the stent as well. So this is the post OCT run. And the diagonal opening was also good. And proximally, when you can see the LCX opening as well as the opening of the ramus was also good. So this is a still picture of the OCT. No distal edge dissection or malopposition. So there was a good expansion of the stent throughout. So this is the nodular calcium before the OCT run. This is the nodular calcium being shaved after the OCT run. So this is after the post-stenting. The fibrous, the tight one, the 95% stenosis. It was the pre-PCA, and this is the post-stent. So the side branch assessment, this is the diagonal one. So this is diagonal 2, and this is the LCX ostium. So this is the final result. It showed good expansion of the stent radiologically as well. So the take-home message is OCT plays a crucial role in identifying the nodular calcium that may not be visible on angiography. So without the OCT guidance, the cells could have been landed over the calcium nodule, resulting in stent under expansion and poor long-term results. So OCT enables lesion-specific treatment planning. It provides confidence in selecting optimal stent and balloon size. It ensures adequate lesion preparation, confirming optimal vessel modification before stent implantation.
Very nice, excellent presentation, Dr. Madhus, and very clear demonstration of whatever you have been explaining with OCT as well as the effect of orbital.
Thank you, sir.
So, and then only thing you suspected something on the angiogram, and then you proceeded directly with OCT, isn't it? That is how you went.
Yes, sir. Actually, patient came on Saturday evening, sir. But the thing is, when we saw the angiogram, everybody said it's a straightforward angiogram. You can proceed with the direct stenting that day itself. But back of the mind, I'm not very confident because most often the filling defect, what we see, sometimes will turn out to be a nodular calcium. We had previous experiences. So I said the patient is not in pain. We'll wait for Monday. So within 24 hours, we'll relook into the case once again. So that day morning, I asked the orbital atherectomy as well as IVL fellows to come to the cath lab. So we took the case on Monday morning, sir. Actually,
Yeah, that is
so in Monday morning, when we, as I suspected, after the OCT, it clearly showed it's a nodular calcium. Previously, we had some experience with one post CABG patient, similar case where the left main was showing some filling defect. Everybody thought it's a calcium, but when we did a OCT, the same scenario, something like that, we found it to be a large nodule. Then we did orbital atherectomy for that patient, and we put a stent. So this patient have the proximal LED having a extensive calcium, probably adventitial calcium in this case, I thought it's always better to have everything prepared before going for the case.
Yeah, that is a good approach. And many times I also get a lot of cases like this. Acute coronary syndrome, something intraluminal filling defect, just resembling a thrombus. It's always confusing. People have tried to attempt and balloon doesn't expand, and then probably they get referred here for intravascular imaging and then further thing. This is a quite common scenario. But only thing is, like, it is good that you suspected and you did a OCT. If in case, probably if you had put a balloon, so and then how do you actually today in today's thinking? How do you approach this nodule? Do you always use orbital or do anything else, some other approach also? Because all patients may not be affordable for orbital, and
So
there are different types of nodules.
actually, we can use rota if have a very good wire bias towards the nodule. So rota we can try. And they say IVL with multiple shocks, we can still have some breaks in calcium, but nodule I prefer usually orbital atherectomy rather than IVL. Cutting balloons, sir, it's very difficult to say because sometimes it may break or sometimes it may not break. So if you use a cutting balloon, then using a gadgets will be very difficult. So probably nodular calcium, I usually prefer orbital, sir.
And then here the nodule was just opposite to another calcified area. So probably this is really relatively a more safer nodule compared to a nodule where the opposite side of the vessel is normal, where you tend to have perforations. And then, but here it was not like that. It was almost around 180 degrees of that area was full of calcium. So probably you could, that is why post dilate more confidently rather than like probably go undersizing your balloon. Have you had any complications with this type of nodules or with orbital so far?
No, sir, actually, the better thing I have seen is assessing the vessel size is very important. So if the vessel size is less than 3 mm, we use 80 2.5 to 3 mm, we can use an 80 RPMs. I think mostly it is safer. Perforations are rare. And when the orbital and OCT is not available, we can use the NC balloon without dilatation and put the that area where we suspect a nodule. We can take a stent boost in two different angles and find out whether the calcium is there in the different areas. So that's another way where when you don't have an OCT, we can identify the calcium nodules. That may be an much practical technique when the gadgets are not available.
Yeah. So any other comments from others here? Dr. Saravanan or Dr. Vignesh, somebody you want to comment something on that? Lijo, you have been very silent, please.
Yeah. So no, my thing is, this is a reasonably common scenario in terms of having a hazy plaque. Now, if image like you asked, imaging was not available, then could we have stented just proximal to it? Because you may not have even dilated the segment, because angiographically that lesion area didn't look significant. It was just a haziness there. What may have happened? I'm not very sure what could have happened.
Yeah, that is a possibility.
So the thing is, so always be very close to that fibrofacty plaque, that the maximum area of what we see, there's an stenosis. Mostly near that particular area, we don't know whether it's a fibrous area where you can land the stent or it is an plaquey area. We had one patient previously, so where we thought is a 90, but not a calcified lesion, but 95% plaque was there in the proximal LAD. We thought it can safely land a stent. So I landed the stent just but the imaging was not used because patient was poor. So once I landed the stent, I thought I saw the proximal part where the stent landed had a intimal tear. So there was some haziness. So then immediately I took an OCT, then saw the landing of the stent. So the landing of the stent was a problem because it landed in the fibroplastic flocky area. That's the lipid area. So the problem here is putting a stent very close to that 95% lesion. We are not very sure. It may be a fibrous area or it may be a lipid. If you land the lipid, then we are going to have another, the chance of acute coronary syndrome in the future or near future. So stent thrombosis, the incidence is high. So usually when there is a lesion from fibrous to fibrous, from normal to normal, stent landing is safer. That's what I believe.
Yeah, other thing is, I think what you said is even if you had entered there, of course, one is edge issues, and also sometimes you know that calcific or nodular calcium itself can cause ACS in the future. So certainly the event risk is much higher in that scenario. Yes.
Any other comments? Dr. Subhash, are you still here?
Yeah, I'm there. I'm still
Yes, sir. Please,
listening
sir.
very attentively.
All right, yes.
Dr. Madhu showed an excellent case,
Yes,
step
sir.
by step, and he has convinced us that how important is the role of imaging today. Let's say if he had not done imaging, and most of us, in fact, looking at angiogram, would have proceeded with simple balloon, and he also did a balloon to pass in his OCT catheter. But I'm sure we would have faced a lot of problem, and that is the time that as one of the experts said, that they put in the catheter midway and then realized their mistake. So it's always good idea to interrogate these lesions where you're suspicious. It looked at a pristine type A lesion, but look at it what it turned out to be. So imaging is really emerging as a class 1 indication across most of the guidelines and should be utilized more and more. Even if there's a constraint of money, one can always use reused catheters. Like in our lab, we have a lot of IVS and OCT catheters, and they can be easily reused in cases of academic interest also. So excellent, Madhu. Compliments to you.
Yeah.
Thank you, sir. Thank you.
Very good. So, are there any other comments from others here? So, there was some question in the chat box. What he has asked is, how OAD selectively cracks calcium, sparing tissue without causing dissection? Madhu, do you want to take this question?
I think the technical team in the
Yeah.
will be much.
Yeah, actually, see, it is something like rota. What we used to say is, it is something like shaving. So when there is hair there, you shave here. When you put a blade, it selectively takes out the hair. It doesn't do anything to the skin there. Similarly, it acts only on hard tissues. So softer tissue gets reflected back. So it is not injured. So this is the actual explanation for that. But in real-time practice, on OCT, I have seen that sometimes even fibrotic lesion gets cracked by orbital. So that we have experienced, but the explanation is actually orbital acts only on calcium and soft tissue gets deflected out. So that is how this works. It's selective, works on harder tissue. That is true for most of the time, but sometimes even in a tight critical fibrotic thing, it can cause some problems.
Even in this particular case, the fibrous calcium was broken and there was a luminal gain.
Correct. And it's a good question. But that Ariaran is asking. So, okay, then we'll go to the next presenter. Who's the next presenter now?
Lijo sir.
Yeah,
Dr.
I can do,
Lijo,
sir.
Yeah, please go
I'll
ahead.
share my screen.
Yeah.
Yeah, the screen is visible.
Yeah, we can see that. Yeah.
Okay, so we do full mode. Yeah. So good evening all. Thank you, Abbott. Thank you, Dr. Salmani sir, for this opportunity. So this is not a very complicated case in terms of technicalities, but it's interesting that was done a very elderly gentleman. How we did a OCT guided complex PCI. This was done by myself and my colleague in KMCH Medical College. So this is a 91-year-old male who's otherwise actively healthy person who came with an androlamide a month ago. CAG showed a triple vessel disease, LAD being the culprit at that time, and proceeded with the primary PCI to LAD, which went uneventful, not too much of calcium. LCX is a non-dominant diffusely diseased vessel. RCA had a very tight calcific long segment lesion angiographically, and he was planned for this later, and he came to us probably around a month later for the same, and that is when we proceeded with the OCT guided procedure for the completion plasty. He's also non-diabetic hypertensive, and to make the matters worse, a borderline CKD with a creat of 1.6, which converts to an EGFR of around 30, and he also had LV dysfunction. So if you can see, this is the baseline angiogram. RCA shows a long lesion right from the proximal to mid-distal junction with visible deep wall, probably deep wall calcium on angiography. And there is some lesion at the crux, but not significant. PLB looks okay. PDA probably is diffusely diseased small vessel. And on the rightmost panel, you can see the LAD stent, which was done 1 month ago, which was normally flowing. Primary angioplasty, which was done earlier. Now, preparation for this RCA, this is done from the radial JR guide, routine wires, pre-dilated with a 2 into 10 mm balloon to facilitate the OCT catheter entry. And the pre-OCT, pre-PCI OCT was performed using 100% saline, considering the EGFR of this gentleman. So this was a saline run, which was done pre-PCI OCT after the 2 into 10 mm NC balloon dilatation. You can see pretty good images for a 100% saline, not much of mix with the blood, done from the distal right till the catheter. And we found 3 areas of significant disease with 3 almost different etiology of plaques. So if you see, point A would be where your reasonable distal landing zone would be, even though there is some fibrofatty plaque at that segment. Point B, there is a fibrofatty plaque with a tight lesion. Point C is eccentric deep calcium and fibrous plaque. And point D is an eccentric superficial. You can see there's a superficial fatty calcium, which is seen on one side. On the other side, it's just a fibrofatty plaque. So you can see 3 different morphologies in the same vessel in this gentleman. And having seen this, we thought we'll take initially a cutting balloon or a scoring balloon. But the issue is we did not have a 3 or a 3.5 cutting or scoring balloon, because that would have been ideal to give a good result in this case. So we actually, what we had was a normal regular. Yeah, before I come to that. So segmental mapping, just to mention all the reference diameters, proximal, mid, and distal, and the MLAs are also marked in the all segments. So we had a 3 into 12 regular NC balloon, which was dilated to around 22, which yielded quite well. At least angiographically, it looked yielded well in all the 3 territories. And then we did a post-preparation, again 100% saline OCT run. Now, as expected, there's a lot of uncontrolled dissection that is seen because of the regular NC balloon, which was done at high pressures. But the luminal gain was acceptable. It was not like that we needed anything further to be done. Surprising, the results were reasonably good, right from the proximal to distal. The luminal gain was quite good. And as expected, there was intramural hematoma in certain areas, extensive intimal dissection that was seen, and of course the proximal segment also yielded, and the luminal gain looked good. And as per the OCT dimensions, we ended with the stenting. The mid to distal was stented with a 3 into 38 alpine, and subsequently the proximal was stented with a 3.5 23 alpine, and post dilated both of the stents with a 3.5 12 NC at 20 atmospheres. And this was the post PCI OCT, again done with a 100% saline. You can see an excellent stent opposition. There is very good luminal gain in almost all the segments, hardly any residue, and expansion is more than 90%. And there is hardly any malopposition almost throughout, right from the proximal to mid-distal stent. There's no malopposition. Some amount of blood mixing was seen right in the terminal part of the OCT. And the segments are 7.57, 5.27, and you can see the results are excellent in terms of stent opposition and the final result. So this is the post and the pre and the post lumen profiles. No significant medial dissection. Stent has been well opposed. Expansion is more than 90%. And this is the final angiogram. There is some lesion, as I mentioned, at the crux, but not really significant. And the vessel beyond that, the PLB is okay, and the RPD is diffusely diseased. And this should be enough for him in terms of the final result. So this was just a case that we presented just to say that OCT helped in optimal blood preparation, stent sizing, and post-optimization. I mean, when we did the primary angioplasty, looking at the RCA, initially thought, I mean, at least to the eye, that it would have been just a maximum 275 vessel with a 3 NC, but we ended up with a 3 and a 3.5 approximately with a 3.5 NC based on OCT, which without OCT, definitely I would not have done. And the excellent clear images with 100% saline OCT. Multiple morphology
Yeah,
plaques were seen within the same vessel. I demonstrated 3 different plaques at 3 different points, and the whole procedure was done only with 50 ml of contrast used. Create baseline was 1.6, 24 hours later 1.5, and 48 hours later 1.6 with hydration alone. So we had an excellent successful PCR result in this more than 90-year-old. Thank you.
So very nice demonstration, the utility of imaging. That too, we have used saline OCT in the RCA. So I think Vijay is already there. I think he can comment something on this case. So you keep commenting, Vijay.
Yeah, it is a nice case, again, illustrating how we always say that if you want to use a low contrast or zero contrast imaging, is only with IVUS. But in this case, particularly in the ACS scenario, OCT helped in identifying many things which IVUS would not have shown. It is a nice demonstration of pre, intra-procedural, and post-procedural utilization of OCT imaging for first identification of pathology, and the second, the guidance of stent, and again, confirmation of stent optimization. It's a nice demonstration of minimum contrast OCT.
Thank you.
So what else do you use? Actually, have you used saline in the left system also?
So that, as you know, especially when the circus reasonably big, it becomes an issue. The images, we did do a case after 2 days of an LED standing with saline OCT, but the images were not that brisk, so we had to mix a bit of contrast and use. So RCA, it was quite okay. LED did have some difficulty. Yeah.
Okay, good. So always it's the same experience at most of the centers. If it is a
The
very
only
big
other
vessel,
time is in an RCA, if you have an ostial lesion and your guide is engaged, then your contrast moves away. Your contrast will keep the blood away for some time. You get a good image.
correct.
But that's the risk of VT.
That is sure. That is sure. And do you use any other media apart from saline?
No, sir. No.
You
What other options, sir?
So generally, people have used dextran, but again, that's
Okay.
also equally nephrotoxic. We have used some starch also. Instead of dextran, we have used starch also to get equally better. The viscosity is more than the saline, both the dextran as well as starch. Probably clearance will be more better. That is thinking. And then these are the alternative things
Right.
that we have apart from saline to avoid contrast.
So this case, actually, we just did 2 initial shots. Then after that, maybe stent positioning time, second set of shots, and then final shots. No angio shots, pre-dilatation, bed preparation. It's all OCT based. So just manage with 40 to 50 ml of contrast.
Yeah, that's the advantage. Actually, in fact, you can do even zero contrast without with saline or this any other alternatives, and probably it gives you very clear images. But only thing sometimes you'll have to do 2 or 3 pullbacks, like in case one segment is missed because
Yes,
of
sir. Yeah.
less clearance, we'll have to do. But that doesn't matter. Anyway, we're
Exactly.
just giving
Yeah.
only saline.
Saline, exactly. Yeah.
Yeah. So very nice case, Dr. Lijo. And I think Dr. Nitish has joined. And if Nitish has joined, are you ready with your presentation, Dr. Nitish?
Yes, sir. Yes, sir. I'll be sharing my presentation, sir. Yes.
Yeah.
Is my slide visible, sir?
Yeah, we can see the slides.
Please go ahead. Please go ahead.
Yes, sir. Yes, sir. So, first of all, thank you, Albert, for giving me this opportunity. It is an honor presenting in front of this esteemed faculties. So, I'd be presenting a OCT and an orbital atherectomy case which we recently encountered. So, this is about a 78-year-old gentleman presented with a chronic stable angina, effort angina. He could not even walk 100 meters. So, diabetic COPD in all the comorbids. So completely denied surgical advice. So this is how his angiogram looked. So clearly there is a specific osteal LAD distal left main and osteal LCH lesion. The TME2 flow, TME1 flow in the LAD, diffusely diseased LAD, and also LCX had diffusely diseased. So our plan was initially wiring the LED, securing the LED, and then doing imaging, and then further proceed with the LED intervention. So this is how we did. Initially wired the LED with the low-cost wire, did a pullback as much as the catheter could go. After the catheter could not go, so we had a pullback from the proximal LED. So this is how the proximal LED pullback looked. As you could clearly appreciate, there was a distal left main calcific disease with an osteal LAD, also significant calcific disease, and more of a calcific lesion in the mid proximal to mid LAD junction. This is how it looked. The EL to EL in the distal left main was around 4, and proximal LAD was 3.5, and mid to distal LAD was around 2.5, 2.75. So, and was heavily calcific. Calcific score was, as per the calcific score, it was severely calcific lesion. So, had to use some devices. Considering the difference in the luminal in the lesion, the left main of around 4 and proximal LAD of 3.5 and mid LAD of 2.75, the only device which we could go with was orbital atherectomy. So, we went ahead. So as I already discussed, this is how the ELD looked. So went ahead and did atherectomy. So wire was exchanged for paper wire through microcatheter. Did orbital atherectomy proximal to and distal left main through retrograde standing was done. And then to get more luminal gain, 120 was 120,000 ATM was done, RPM. So, and the further bed preparation was done using 2.5 NC balloon from proximal to mid LED. This is how it looked after check shoot. TNT flow. Distal LED was also prepared using 2 NC balloon, followed by 2.5 scoring balloon was used. Aperta scoring balloon was used and prepared from osteal to mid LED. Using 2.5 into 48 DES proximal to mid LED was stented. This is how it looked after stenting proximal to mid LED. And then for LCX lesion, we prepared using the same 2.5 into 13 upper tub balloon from proximal to mid and distal. Our plan was to hybrid approach, doing DB to the LCX and then proceeding from left main to LAD side. So, and then 2.5 into 20 DCB was used, Crottage. Same balloon in the mid and proximal junction. And then using 3.5 into 30 megatron proximal to left main LED was stented, overlapping distal stent. Pot was done using 4.5 NC balloon. And then since EL to EL in the proximal LED was 3.5, optimization was done using 3.5 NC balloon. Good flow in the LCX, since wire was removed and distal part of the overlapping segment and the distal part was dilated using 2.75. And then beyond the stent, the distal LED portion was dilated using 2.25 into 20 mm DCB. This is the post DCB final run. Good opposition with no malopposition or edge dissection. So you could see LED was diffusely decreased beyond the stented segment. So minimal lumen area which we achieved in the left main was 9.4, proximal LED of 7.9, and distal MSA was 3.76. That is what maximum we could achieve. So this is the comparison of the pullback. And this 3D view beautifully demonstrated the LC ostium. There were strength sets, but good flow on the LCA, so didn't intervene. This is the final shot showing TME3 flow in the LED, a reasonably good result in the LED, and LCX was also a flowing vessel. Thank you. Thank you for the opportunity, and I would be happy to have your comments.
Yes, Nitish. Anyhow, your angios were basically was not very clear here because of the network issues, I think. But what I could understand is it was a severely calcified lesion, very diffuse disease from proximal to distal LED, and circ also was diseased. And what you have done is probably you did a OCT at the beginning, but final OCT was not shown, or probably you did not do, we are not sure. And probably did you do an OCT finally after stenting?
Yes, sir. Yes, sir. I had shown probably because of the network issue. I think you will not see it, sir.
Yeah, we could not see that
see
OCT.
that, you can share one thing also, able to see that.
We were able to see. Okay, good. And the utility in this, you have used a 2.0 Ultreon. And
Yes, sir.
could you identify the calcified area? Did you? Because
Yes, sir.
of network, I did not understand. Probably you would have shown.
Yes, sir.
And,
Yes, sir.
I couldn't understand, but probably somebody has asked on the chat also. You can highlight how 2.2 helps you in identifying calcium or making out the EL. Can just tell the audience, probably it will be useful for them.
Yes, sir. So we kept the cutoff as 180, as we know that calcium mark more than 180 degree, more than 5 mm and 0.5 thickness is a severe calcium. So we kept the cutoff as 180, and there were many areas where there were calcific lesion more than calcium mark of 180 degree. So Ultreon clearly, when we kept 180 degree, immediately after the pullback, it showed the areas in orange had more severe calcific lesion. So we immediately went there and confirmed the thickness more than 0.5. So we had to use some atherectomy devices to get away with the calcium. Yes, sir.
No, for in this diffuse calcium, how did you do orbital? Because we couldn't see the angiogram. So
Yes, sir.
you did right from proximal to distal, or how? Yeah, for
Sir,
how many runs did you do?
Sir, first initially with 80,000 RPM, we had to go from proximal LED to the mid junction, sir. Then retrograde sanding from LED to the left main, sir.
You just did
In
one
120
run.
RPM. 120,
Okay.
yes, sir.
Vijay, any comments you want to do?
Yes, I also could not see fully, sir, but it is a complex left main bifurcation, and I think it did a drug eluting balloon to LCX and OCT guided PCI to left main to LED. we showed final results. Final results look good because despite this extensive calcification, final results and OCT areas, even though little smaller in the distal part and proximal part and left very good areas. So nicely done.
A very tough case, but any of the
Yeah, very
results good. And then it was a Timmy
5 runs altogether, I think, right?
Yes, sir.
5 runs of orbital.
Yes, sir,
And-
5 runs of orbitals. Yes.
So, do you have any criteria like when you treat the circumflex after stenting? Do you routinely do kissing or you have some selective ideas?
So there is two schools of thought. One is recrossing it again and opening the struts of the LCX, and other thing is leaving it alone when there is 23 flow and there is no dissection. Flow limiting dissection is not there. Leave it. That's what, sir. In this, there was no flow limiting dissection, and OCT wise, there was good lumen in the LCX. No pinching of LCX, so had to leave it, sir.
So, did you see any connectors or struts?
Yeah,
across the
there were
circumflex?
connectors and struts across the LCX. But your expert opinion is needed regarding this, sir. So do you routinely open the struts in the LCX after doing left main to LED PCA, or how do you go about this, sir?
See, as you rightly said, it's always controversial. But my approach is because most of the time we do under image guidance. If
Yes, sir.
we see any connectors,
Yes, sir.
we'll kiss. If there are no connectors, generally we don't kiss. That is how we approach. So, but it can vary. It may not be the guideline, but probably when you are using imaging, if you don't see any connectors, there is no point in doing a kissing there. So
Answer.
that is how we work. And if there
So
are
what is the
connectors,
balloon
we do.
size you choose, sir? For is it 1:1 LCX or size, or how do you do it?
You can do it in two ways, probably slightly undersized so that your aim is to just push that connectors away and then kiss it. Or probably if you feel there is real pinching, you can still go 1:1. But the problem is you can produce some defections in the
Dissection.
side branch. Yeah.
Yes, sir.
Vijay, any comments on this?
The key is not extending the balloon too much into the side branch. So just to keep close to the ostium, just move the sets away. So that is, if we extend too much, then there may be the chance of dissection, and use non-compliant balloon. So and with either size 1:1 or little smaller than the side branch size, but not to extend too much into, because your aim is just to open the this thing, side branch ostium. And still we don't know. There is, I think, there is a 600 patient study is undergoing in India. I think most probably in near future we'll know whether it is really benefits or not. Again, it's very difficult to get clinical outcomes. For that you need a huge population study.
Yeah,
Again,
huge population.
outcome is only angiographic restenosis during follow. So whatever studies we had, side branch you dilate, the side branch outcomes are good, but the main branch outcomes are not great. Then that evens out. So no definite improvement in the outcomes with the side branch dilatation. So we'll just see that how that other study goes.
A very nice case, Nitish. Complex.
Thank you,
one.
sir. Thank you, sir.
When was this case done? How
Sir,
long?
2 weeks back, sir.
Okay, fine. So this type of patients need to be followed up because
Yes, sir. Yes.
distal runoff in the left main is very, very important because they can land up in trouble anytime.
Mhm.
Long diffuse disease. If the outflow disease is not treated well, they can have a lot of issues.
Yes.
But anyway, a very good, complex case. Nice
Thank you.
presentation.
Thank you, sir. Thank you, sir.
Yeah. And I think Dr. Anand is not here. Anand has joined or what? I
No,
think-
sir, he is in primary class.
No, he is stuck in some primary plastic. Okay, Vijay, do you want to present now? Or Ram Kumar is requesting me to show one case. So
Sure, sir. Please go ahead.
what I will do is I will just show you one case. But since we were discussing about this zero contrast, I will just show you one case probably, which might be some discussion we can just have on that. So just give me 2 minutes. I will just open that presentation. Yeah, yes. So I'll just share this case and then probably we can. Okay, are you seeing the slide?
Yes, sir, we are seeing.
Yeah, okay. So since Lijo was showing that, I thought I will just show you this case also. And there is a lens mark. Okay. So this patient actually had an inferior wall MI, and we did a primary angioplasty to this RCA. So our primary angioplasty was done, and patient recovered very well. And but this is the RCA which we did. 2 days later, this was the LAD lesion. So we wanted to treat this lesion now. So what happened is, like, probably his creatinine started rising. It is 2.4 now. And then in such cases, this is a quite frequent occurrence nowadays in our center also. So what we do is probably you can ask them to come back after some time when the kidney functions improves, but sometimes patient may not be willing to come back, or probably we wanted to do it. In such cases, nowadays we have started using zero contrast PCI. Of course, we use IVUS. Here I will show you how we do it with the OCT also here. See, this is the baseline angiogram which was done initially when, 1 second, let me take the pointer. When we did the primary angioplasty, and now we are planning for a zero contrast. So you just keep this as a landmark now. So this is the roadmap. So now this is the angiogram that we are having here. And our aim is to decide which is the tight lesion and what is the type of lesion. And of course, we are having some 1 or 2 diagnoses here. So we need to have some skeleton-like base. So what you do, what we have done is we have just crossed the diagonal. So you know that we are here, and probably we'll have to land our distal stent at this point on an angiogram. And of course, since we have angio co-registration also, it is going to be good. But it is a little bit tight lesion here. So you may not get a very good clearance. So we have dilated with a balloon there, just keeping this wire as a roadmap. And then this is the saline OCT. So what I have done is I have just kept some guide extension also here into the LAD. We have kept it in the ostium of the LAD. So the main point is, if you are injecting saline from the guide into the left main, many times your clearance is not good. So keep your guide at the ostium of the LAD, or if you are finding it difficult, you keep an extension catheter there, and then you do a pullback. So this is what the OCT looks with in the left system, where we are doing this saline injection, and then you can make out the morphology. And many times, since it's a long lesion from here, from mid LAD to the proximal LAD, just with saline injection, you may not get complete clearance in one run. So you might have to do some 1 or 2 runs in case if your clearance is not good. See here, we are able to see the distal vessel here. And it is so clear, it is interpretable image. We know that at this point there are some calcium, and we know the lumen diameter, and it is not a circumferential calcium, probably calcium between around 12 o'clock to 3 o'clock. And all this morphological identification is possible with this saline OCT and the left system also. And then you make a point here, you just make it a roadmap here, and then you look at the morphology. Like we did 2 runs, one in the proximal, one in the distal. And then we know that what is there where. And then it's basically a fibrocalcific lesion, not really much of lipid there. So we have used it adequate preparatory devices. And I really don't remember what balloons we have used because it's been quite some time. Just ad hocly presenting this. So now we know that he requires to be landed near the ostium. So this is the point where we need to treat here. Probably we'll have to land to a stent at the proximal segment. So what we do is you can take away this wire or keep the wire or keep one more wire. Take a wire and just wire the ostium into the circumflex. So once you are into the circumflex, you will know where is the ostium of the LED. If at all you have still doubt, there is nothing wrong in just giving a small drop of contrast just to see the ostium of the LED. I think, but in this case, we did not give that also. We just kept the circumflex, and we were very sure because exactly ostium was little bit free of disease. Even if you miss a little bit of ostium in the LED, that's okay in this case. So we did not do that. We have just kept the stent there and deployed there, keeping the circ as a landmark there. And of course, distal stent, we use this diagonal as a marker, and then we have deployed the stent. And you post dilate according to the OCT guideline, OCT sizes, what you have seen. And after post dilatation, you do this again a saline run here. So this is again a saline pullback that we are doing. And once you do this, it is very clear. You look at the image here, and you see that the stent is very well deployed. And probably there are some deeper calcium, which we have expanded well. Lumen gain is good. And of course, you can make out even the side branches take off how it is with just saline injection there. So this is the OCT that we got. And look at the ostium, near the ostium we have just landed, and with probably good expansion. We have not just come into the left main or near the ostium. We have just left the ostium here and then stented. And distally, there is no any dissections there. Proximally also, there is no dissection. You can make out the stent expansion. And probably we had some areas of under expansion, which we again dilated. You can even have a 3D reconstruction there to see how it looks. And this is how this was done. And then, of course, you can pick up even side branches. Actually, and I have just missed it somewhere. I think you can make out the side branches also flowing very well. And we did not do a final check angio. We just finished off with this lace with OCT here with this good result. And we do an echocardiogram in case if there is any collection or no. That is what we do in such cases. This system has been used for IVUS also. And similarly, in probably around 50 to 60% of left-sided lesions also we can use saline. But in case if you are really unable to get a good clearance, you can mix 30% contrast and try. Probably you can get a similar image. But in almost at least 50 to 60% of cases, we are able to do this saline OCT on the left system also. I'll just stop here. Thank you so much.
Nice case, a nice demonstration of OCT in the left side. So
Yeah.
sometimes another small trick is when you know the distal landing zone, you have an OCT image, exact length of the stent is enough. You don't have to even keep the LCX square. Suppose you know that from distal landing zone to proximal landing zone, the length of the stent, exact length, you're going to implant a single stent, and you don't have to even keep that LCX.
Yeah, correct. See, in a case like this where the ostium was a little bit free of disease, that's an advantage. If the lesion extends, probably I think we'll have to be a bit
And
careful.
even for left main ostium, you have a distal landmark, and you know the exact length of the stent. You just take 1 millimeter extra, land at the distal, then you don't have to struggle to image the ostium.
Ostium, yeah, that's a good idea. So, any comments from others there?
Sir, good evening, sir. This is
Yes,
Dr.
Mr.
Vijay. Sir, you're talking about using a guide plus for using a saline OCT. So, how effective is it in case of multiple branched vessels like LED with a huge diagonal taking off?
See, that is what I'm saying. You may not get it in all the cases. So probably my experience is we can get it in almost 50 to 60% of cases in the left side also. It
Okay.
all depends on the size of the vessel, one, and where you keep your guiding or the extension catheter. So if you are able to take the guide itself into the ostium of the LED, then many times the clearance is very good.
Okay.
If you are unable to do that for some reason, if it might be a long left main or calcified where you are unable to take the guide inside, take a guide extension, keep it at the ostium of the LED, And make sure guide is also hooked. That's a very important point.
Okay.
Guide also should be hooked, and then guide extension at the ostrum of the lady, and then inject saline, and then you will get a reasonably good images.
Okay.
And the other important thing is even if we use contrast, you end up using small amount of contrast compared to left main injection. So if you use a guide extension, even small amount of contrast, even 5 ml of contrast, you'll get a very good images.
Yes, actually, the case that Lijasa presented, I was with him, and the second case he was talking about, we did it on the left side. So we ended up mixing some contrast. I think it was a ratio of 3:7, 3 ml of contrast with 7 ml of saline. And but even then, I think what Sir said was very important. The hooking of guide, we could not get the guide to sit comfortably. It would always come out when we tried to inject, and we had issues with that. But otherwise, even despite that, 3:7, 3 and 7 ml of saline gave a reasonably good interpretable image on OCT. So I think guide placement is also a big position thing.
Yeah, see, that's the important point here. See, OCT guide position is even for contrast. If your guide is not in good position, your clearance will not be good. That
Yes,
is
sir.
for a long lesion like this.
Yes.
And
Yes.
then, so getting a good image is very important in an OCT.
Yes, sir.
So yeah, that's.
Thank you, sir. Thank you so much.
One other thing, if you have the dynamic angio, so the one injection is enough. You can just keep the OCT screen as your main screen, and you can complete the entire this thing with 1 or 2 injections of contrast.
Yes, sir.
There are many ways of doing it. And if you have in addition Philips dynamic coronary roadmap, so all these things help in reducing the amount of contrast.
Yes, sir. Thank you, sir.
And now, if there are no other comments, any comments in the. So, Ariaran, in case of distal left main calcification, does OAD, is OAD indicated? See, actually, that question, it all depends on the luminal area. Even if it is in the distal left main, if the lumen is very tight, if there are calcified nodules there, you can use orbital. So what happens is probably it will go touch the calcium and it will modify the nodules there. It can be used in distal left main, but as you're probably, I understand your question, since the left main is 3.5, 4.5 or 5, will it be useful? Yeah, definitely. If the lumen is narrow, if there is significant superficial calcium or nodules projecting at the distal left main, OAD is very, very useful. We can use it. Vijay, any other comments on this? You want to say something?
Yes, sir. That's it, sir. Because nicely, everything has been covered.
Yeah. It's over to you, Vijay. You can take over.
So I'll just quickly show next 5 minutes the recent trials which led into class 1 indication for coronary imaging. Okay? So I'm just going to show very few trials. I am not going to take a lot of your time. So the past maybe 12 months to 24 months, a lot of data for intravascular imaging, both IVUS and OCT, which led to both the two major societies, European Society of Cardiology and American Heart Association and American College of Cardiology. Both have recommended, given a class 1A recommendation for usage of imaging in patients with a complex lesion subsets, particularly with a left main bifurcation and another complex lesions. So I'm just going to show a few of the trials which have been presented recently. And we all know class 1 is it is recommended or strongly indicated. A means the data derived from multiple randomized trials or meta-analysis. So that is what the current recommendation for imaging is. And this is your recent ESC guidelines. So intracoronary imaging, either IVUS or OCT is recommended for performing PCI, anatomically complex lesions such as left main stem, through bifurcation, and long lesions. It is a class 1A indication. And this is your recent ACS guidelines from ACC AHA. Again, it has given indication patients presenting with ACS, undergoing coronary stent implantation, again in coronary left main complex lesions and bifurcations, intracoronary imaging. either the IVS or OCT is recommended. Is again a class 1A indication. So it is recommended both in chronic coronary syndrome and acute coronary syndrome, wherever you deal with the complications. And compared to IVS, OCT offers specific advantages of reducing calcium thickness, identifying the lipid-rich plaque properly, and one only modality which identifies thrombus and fibroatheromas and tells you what is an exact underlying pathology, whether it is plaque rupture, erosion, or calcified nodule. And then again, it gives you a good indication of the mode of stent failure, whether it is resulted from biological causes or resulting from mechanical causes. And recap of evidence, these are the recent trials, Illumian 4, October, OCT, IVS, network analysis, that is of multiple trials, both IVS and OCT, and recent trial, and OCT, which is the OCT guided versus angio-guided interventions. And this network analysis of nearly 12,500 patients comparing OCT, IVS versus angiography, which has shown significant reduction in target vessel failure, cardiac death, all-cause death, target vessel MI, all-cause MI, stent thrombosis, and DLR. All the endpoints, either it is a safety or efficacy endpoints, everything is much better with intravascular imaging comparing to angiography guidance. And this is Illumian 4 trial. This is one of the major trial, 2,500 patients comparing angiography with the OCT guided PCI in complex lesion subsets. Even though the trial met many outcomes, and the major outcome, that is your target vessel failure, was not different from angiography versus OCT guidance. This is maybe the only negative trial that has been presented in the recent past. Even though there are many other things have been speculated as the cause of negative outcomes comparing to positive outcomes in almost all the trials. So despite the negative clinical outcomes, this trial has made this reduction significant improvement in MSA comparing to angiographic guidance, significant reduction in the major dissections, incidence of major dissections, incidence of major malposition, and the reduction in the major tissue protrusion comparing to angiographic guidance. And this is what the significant difference in the major means indicator of adverse outcomes with angiography and OCT outcomes. And this is the major, what we are worried about, safety outcomes, stent thrombosis. There was a significant 1.1% absolute reduction in the stent thrombosis rate comparing to angiographic outcomes. And coming to the safety outcomes, there is a significant improvement in the safety outcomes comparing to OCT guidance. So there is a larger major MSA and fewer major procedure-related complications and fewer serious major outcomes, even though there is no significant difference in the target vessel failure. And if you see the outcome of the patients in the same trial, in the patients who had significant angiographic calcium, OCT guided intervention is associated with a significant reduction in the target vessel failure. That is a significant 38% reduction in the target vessel failure comparing to OCT, IVS means angiography alone. And the second one is your October trial, that is both left main and non-left main bifurcation. The trial is adequately powered to show the reduction in the clinical outcomes. So this trial has shown that 4% absolute reduction in the cumulative MACE after 2 years in the OCT arm compared to the angiographic outcomes. And when you achieve OCT outcomes and you do the final OCT, and there is a significant reduction in the outcomes comparing to angiogram alone. And the next randomized trial is Renovate Complex PCI. This included both IVS and OCT in the major guided arm, which compared to the angiographic outcomes. You can just see that significant 5% reduction in the clinical peak points comparing to angiography whenever used in imaging. And in this, whether you use an OCT guided PCI, that improved outcomes. Use an IVS guided PCI, improved clinical outcomes. There is no significant difference between the OCT versus IVS guided utilization outcomes. So these three trials which have shown that using imaging guidance, OCT, particularly the OCT guidance, improved outcomes comparing to angiographic guided outcomes alone. The recent OCT trial, again OCT versus coronary angiogram, and 1,604 patients, and 1 year follow, there is significant reduction in the composite outcomes of target vessel failure by the 38% reduction, 4.6% versus 7.4%. The secondary outcome, spontaneous MI, was significantly 64% reduction in this spontaneous MI and 64% reduction in the target vessel revascularization. And OCT IVUS, comparing IVUS versus OCT, there is no significant difference in the outcomes between IVUS and OCT. Even though there is an increased contrast utilization with OCT, there is no significant increase in the contrast induced. And again, three other registries. This is an ACT registry, TACTIS registry, and this trial, which has shown that whether OCT has really improved outcomes in patients with a STEMI undergoing primary PCI. And this trial, which has shown that, again, the different type of pathology, which is the plaque rupture, which is the most common pathology, erosion second common, and the calcifying nodule, the third common, and others contributing about 11%. And OCT could be used, and when you use OCT, there is a different type of modality, the underlying pathology you identify, that result in different type of outcomes. When you have plaque erosion, you have the best of the outcomes. And when you have plaque rupture, second best, and you have calcified nodule, that result in very poor outcomes. So OCT clearly shows that which patient is going to do poorly on long-term follow based on the underlying pathology. The next registry, then optimal registry, again, which is a registry of 66,000 patients. It is in China. And as in 1 year outcomes, we see that OCT guidance was associated about 50% reduction in the all-cause death and cardiac death. And finally, Atlas OCT registry, which is used that whether the primary PCI, your OCT guidance seems feasibility and outcome registry. And it is OCT guidance was feasible in about 78.5% of the patients. And it was able to identify, used to assess the morphology guidance in 72% of the patients, stent sizing in 70%, and stent optimization in 71% of the patients. And this is what the various different pathology has been identified. And it has resulted in change in the stent sizing in about 60% of the patients, and change in the stent optimization in about 54% of the patients. And to summarize, OCT guidance or imaging guidance has resulted in significant result in target lesion failure and significant reduction in all the outcomes, cardiac death, and reduction in target vessel MI, target vessel target lesion revascularization, reduction in stent thrombosis, reduction in all-cause death, and reduction in all-cause MI, and the reduction in the outcomes of your suboptimal PCI, reduction in lesser amount of dissection, lesser malabsorption, lesser tissue protrusion, and a significantly improved stent areas. And it is OCT guidance is non-inferior to your IVUS guidance. So, and with the current Aldrian 2, and you have everything available in the single screen, whether pre-PCI assessment of calcium, pre-PCI assessment of your landing zones, and your length assessment and stent sizing, and post-PCA assessment of your outcomes. Everything is much better than your OCT guidance. Thank you.
Very nice, clear explanation, Dr. Vijay. And it is really probably we have a lot of evidence now compared to a few years back where we were always talking about evidence and then use of OCT. And definitely it is a good thing that. How was your utility of OCT in acute coronary syndrome? Do you routinely use it, or at least try, or what is your practice? Theoretically, we know that.
And again, see that it is it is known, well known, that identification of underlying pathology, that is your major determinant of outcomes. You have your plaque rupture, means your plaque erosion, that has the best outcome. So most of the time, you end up not stenting those type of patients, particularly in younger patients. and you have calcified lesion, particularly in elderly patients, that is where your outcomes are poor. And we try to use it whenever feasible. You all know that it is in our scenario using intravascular imaging for all patients presenting with ACS. It is very difficult scenario, but whenever feasible, and it gives a definitive indicator, it is of outcomes, particularly what is your long-term outcome in patients with ACS. Try to use as much as possible, but it is again not feasible to use in all patients presenting with ACS.
Yeah, that is true. That is true. But of course, at least in complex PCIs, left
And
main,
complex,
yeah, of course.
absolutely complex.
Absolutely, probably it must be utilized in a better way. And any other comments, Dr. Shubhas? Are you still here? I think he was in the hospital. Probably he must have gone back to his case or something. So anyhow, thank you so much, Dr. Vijay, for joining us. And all the presenters, they did a very great job, good presentation, and definitely a good exchange of knowledge. And then probably it might be helpful in one scenario or other. Probably I think it was a very good discussion. And it's over to you, Ram Kumar. You can just conclude.
Yes, sir. Sir, thank you so much, sir. And this is part 9. This is the 9th event in the series of ACS, CCS, the class would make guidelines for recommendation for OCT. And this all these 9 programs, whenever there is a requirement, you've been always there as a moderator, and whenever there is a requirement for the speaker. So being a senior imaging operators, and you've been there and disseminated a lot of science behind that OCT. And this season actually, maybe for this series, it will be end today. But the next series definitely actually again will come up with the same kind of program, and we will meet soon, sir. And Vijay Kumar sir, and actually the pioneer for imaging, and I used to call God of Imaging for South India. And excellent contribution being there. In this program, you made this event as a more scientific session, sir. And actually, in many of future program, actually your endeavor and your support needed, sir. And Sudha sir, and thank you so much, Subha sir. And you made this event as a pan-India program. Thanks a lot. And for other Dr. Manogar sir, thank you so much. And Dharmaraj sir, you being as a panelist, and thank you so much. And Saravanan sir, Nitish sir, and also Dr. Madhu sir, Lijo sir, excellent presentation, being a lot of discussion of the OAD and other things. So thank you so much from our team, Mr. Vignesh and Satish also. Thank you so much, sir. Thank you, sir.
Thank you. Thank you so much.
Okay, thank you. Bye, bye.
Thank you.
Thank you. Bye, bye, bye.